Hi all, we are here at the 7th European Aniridia Conference in Stockholm, Sweden. 3 days of work to talk about the future of treatments in Aniridia. In this moment we are together with Mariya Moosajee, who is Professor of ophthalmology at University College of London and obviously medical doctor at Moorfield Eye Hospital. Thank you for being with us.
Thank you very much.
So, Mariya, with you we want to talk about the importance of having a good genetic diagnosis and also about the impacts of metabolism on the people with aniridia. So, about of this, starting from the genetic side, why is so important to have a good diagnosis and what you found in your research about it?
Okay, so it's really important that every patient with congenital aniridia has a genetic diagnosis. If a child presents to us with features of aniridia, the first thing that we need to do is ensure that we rule out any chance of that patient having Wagner syndrome. Mm-hmm. So we need to do a genetic test to ensure there isn't a deletion of the neighboring gene WT1 with PAX6. Because if they have that, they have an increased risk of renal tumours. Called Wilms tumor. But then going forwards, we need to establish the molecular diagnosis if they don't have Wagner. So if it's PAX6, there are also genes that can mimic aniridia. So you see lack of the iris, it looks very much like aniridia, but it's a different gene, not PAX6 causing it. And then that has implications on the other features of aniridia. So a big debate at this meeting is whether aniridia itself is a syndrome or an isolated condition. And the answer is it's a syndrome. It isn't just an isolated eye problem. You have the eye features, so the lack of the iris, the foveal hyperplasia, cataracts, glaucoma, corneal disease, but you also have features in the rest of your body. Mm-hmm. So aniridia patients have a higher rate of obesity, diabetes, autism, attention deficit hyperactivity disorder, sleep disturbances, anxiety, depression, and other neurological defects like central auditory processing disorder, anosmia. And this is because of structural defects in the brain and also the effect of PAX6 in the pancreas when in early development. So you're prone to these endocrine problems.
And under this point of view, in your second intervention today, you talked about the problem linked to the metabolism and what you found about it and what are the challenges and opportunities to treat this segment linked to aniridia.
Yeah. So we took a group of aniridia patients and we took a blood sample from them and we compared it to age and gender match controls, and we looked at over 1,000 metabolites in the blood, and we found that significant groups of biochemical agents were disrupted in the aniridia patients, such as disruption of lipids, high levels of oxidative stress, increased levels of some neurotransmitters in the brain, and all of these have an effect on the systemic features. So a lot of them point towards the obesity, high blood pressure, the pro-diabetic state, glucose intolerant state. And so all of these things then point towards whether we need potential treatments to direct towards those systemic features. So should patients be given metformin early on to prevent diabetes? Should they be given obesity weight loss measures? Should children have behavioral assessments for autism and ADHD early? So all of this work basically points to aniridia affecting not just the eyes but the rest of the body. It's important to do genetics to find the genetic cause and then think about treatments not just for the eye but the rest of the body.
And we hope that this kind of treatments will be treated more and more as an ecosystem of symptoms and a syndrome, obviously, as you said. And thank you for your spotlights and for your advices.
Thank you so much.